everyone. So you got me today, Danny. So I'm going to talk to you today about scope of practice, why it matters, what it actually unlocks for your practices. So a little bit about me, for those that don't know me. I'm a compliance specialist at Agilio. I'm also a dental therapist. I'm also a dental nurse. I've worked in a lot of different environments, specialist referral centres, hospitals, private practices, NHS practices. So I completely understand the different constraints that people have and also how busy everybody is. So I understand how scope can be a challenge as well for practices. So I'm quite keen on keeping everything really simple. So I like to try and keep everything effective, make it profitable for practices, but also keep it simple, because when it gets complicated, it gets confusing. So today we're going to talk about a few fitness to practice cases that have come up, a healthcare inspection example, where practices have failed because people have been working outside of their scope. So it's quite a good eye-opener, and it'll help you just take a step back and just go, okay, this is what we're doing at the moment in practice. Are we doing it right? Is there anything that we can do to make improvements? But also where there's opportunity to unlock as well. You know, can your dental nurse do some extra things to help out and improve efficiency? Or can you get your therapist to do a few more restorations to relieve your dentist pressure? So there's loads and loads of options with scope of practice. And then we'll just have a look at what actually scope of practice is. Now, I'm not going to teach you to suck a lemon. I'm not going to list off what a dental nurse can do, what a therapist can do. We're more going to cover things like where it goes wrong, where people step outside of scope without realising. And then obviously we're going to look at some opportunities as well for your business. We're just going to touch on that. And then common queries that we get through at iComply, where we're being asked, can somebody do certain things, or we're not sure about this. So we're just going to cover that as well. So first of all, just to get you thinking about scope of practice, and it could be what's going on in your practice at the moment, it could be what you've heard or you're not sure of, but there's 3 questions here, and hopefully by the end of it, it'll be a little bit clearer for you. So question 1, can a treatment coordinator who is not a GDC registered individual take an intraoral scan? So the poll will come up in just a second if it's not already. So I'll give you a chance to start answering that. And then the second question, can a trainee dental nurse take clinical photographs? That's quite a common one that we get. And I'll go through the what people think at the moment as well afterwards. So do you think a trainee dental nurse can take clinical photographs? And then finally, can a dental therapist prescribe antibiotics to a patient with a dental infection? Just waiting for those answers to come through. So for the first question at the moment, most of you are thinking no. There's a few maybes, a couple of yeses. For the second question, we've got quite a mix actually. It's about 50-50 yes and no. So hopefully we'll get that one cleared up. And then the third question, we've got quite a few yeses, majority no's, a couple of maybes. So again, hopefully after today, all these things will be cleared up and it'll make a bit more sense to you. So when things can go wrong. So these are examples of some fitness to practice cases. Some of them were opened up, some of them went on to fitness to practice hearings, where the individuals had restricted duties afterwards as the outcome. But there's quite a range that comes up in terms of what people do wrong. Often it's a very similar theme of trying to help out a patient or just doing a little bit extra because you've seen it done a million times before, so you think you can do it, or you've been pressured into doing it. Somebody's asked you and you feel like you can't say no. But that's where we have to be really, really careful in terms of protecting ourselves, but also protecting the practice as well. So examples here, we've got clinical dental technician providing partial dentures without a prescription from a dentist. So a clinical dental technician can provide full dentures without a prescription, but not partial ones. And this complaint came because the dentures weren't fitting properly. So it's just important that we often use clinical dental technicians, probably more from the private dentistry, particularly like implant placements or more complex care where it needs a lot of lab work. They tend to get a lot more involved. Some of them also work alongside general treatments as well to provide those full dentures to patients. But often that's where it can get a little bit confused. We also have another dental technician one there where we had a dental technician providing dentures and they weren't working alongside a dentist or a clinical dental technician. So dental technicians will need a prescription in order to make dentures for somebody. So again, it's another one where it's just getting that slight confusion. It's probably helping somebody out. Again, we've got to just be really careful. A concern was raised about an orthodontic therapist potentially working outside of their scope of practice. I don't have any more information on that case, unfortunately, so I can't tell you where it went or what they were apparently doing. But it's one of those goes to show that just a concern being raised about somebody working out of scope can go to fitness to practice. We also had dental nurse providing tooth whitening directly to patients. Now, I've come across this quite a bit where a dentist might ask the dental nurse to provide the whitening trays or just go through the instructions with them or show them what to do. That's part of the tooth whitening process. So that's what the dentist needs to do, or the therapist, hygienist, clinical dental technician, if they've got that prescription. So that one's quite a key one where people do get a little bit confused. And then finally, it was reported that a dental nurse provided local anaesthetic and a restoration to a colleague. So again, working outside of that scope, a dental nurse is not trained to provide restorations or to give local anaesthetic. So it's just all about being careful, protecting ourselves, protecting the patients. With your dentures, you could cause harm to soft tissues if they're not fitting properly. With your local anaesthetic, your restoration, there's all sorts that could go wrong from there in terms of the wrong drug use. You've got using the high-speed handpieces, you can have a lot of damage done with those. So it's just about being really, really careful. Then we've got another example. So this was a CQC inspection where the inspector picked up that there was no dentist currently at the practice due to being short-staffed. So there was a therapist and a few nurses. And they found that staff were working outside of their scope because they were providing dentures to patients and also antibiotics. So, and in addition to that, the antibiotics were not prescribed in line with the current guidance. So whilst patients were being cared for, they were being given their dentures, their antibiotics with the toothache, they were not being provided by somebody suitably trained or skilled or even indemnified. So this means that patients are at risk of harm because everything wasn't being prescribed or given as somebody should be trained to do. So the CQC regarded this practice as in breach of Regulation 12, and they served a warning notice. So it goes to show that not only will it come from the GDC aspect, but you can also be impacted on your healthcare inspections. The other thing to be aware of is that in terms of a GDC complaint, often that can then trigger a CQC inspection. So whilst I'm not trying to scare you, GDC complaints do happen, but if there is enough evidence to give rise for the CQC to want to come and make sure that patient care is safe, the CQC may then visit, or HIW, or whichever region you're in. So it's really important that everybody is aware of their limitations. So what actually is scope of practice? Because we bat around this term a lot, but what does it actually mean? It's what you're trained to do as your registrant. So you'll be competent to do it. So you've got to be confident and competent. You've got to be comfortable doing it. It fits within your registered title. So you can't be registered as a dental therapist and you do root treatments. You can't be registered as a dental nurse and then do an orthodontic bond up. So you've got to make sure that everything that you're doing is within that training that you've had. And you've also got to be indemnified. So this is something that people often worry about, but your indemnity is there to protect you and they're there to help you. So if you're ever asked to do something, or if you think, oh, maybe I could do that to help out, but you're not quite sure, it's worth giving them a call and just asking them. It's not going to increase your premium by just ringing and asking them. And they're normally really, really helpful. I know when I've spoke to them quite a few times, the advice that they give is sound, easy to understand, and it means you can go back with a good solid answer. If you're asked to do something and you're not sure, go ahead and ask them, see what they say, because if they're not going to protect you, you don't want to do it, because you don't want those fines coming back on yourself. With further training, you can carry out additional duties within your scope as well. So what that actually means is when you qualify, you're considered a safe beginner, but you may find you want to expand on your skills. Maybe you want to do more as a therapist, more cosmetic treatments, as in composite bonding. You don't tend to do that on your general training course, but you can do it because it fits under a restoration. As a dental nurse, you may want to go on to do conscious sedation nursing, orthodontic nursing. There's so much that you can do as a dental nurse, placement of a rubber dam, clinical photography. So there's absolutely loads that you can do. We often don't unlock it. Often it's with practices being so busy. We often forget that there is so much more that we can do. So some of you will probably be aware that the GDC updated their scope of practice guidance in November 2025. So the key take home is the scope of practice for each individual professional title has not changed. What has changed is the way that it's described. The purpose of it was to improve clarity, because previously you should be familiar with that document, or you may be anyway if you've been in dentistry a long time. It was a list, like a bullet pointed list of everything that each role could do. Now, the GDC changed it so that it was more open, so that it wasn't as prescriptive. So you can do X, Y, and Z. So it's to be more adaptable, because all practices are different. As a therapist myself, what I would do in practice would vary from a practice that does a lot more cosmetic treatments, for example. And then you've got like your dental nurses. An ortho dental nurse is going to do a lot different treatments, a lot different chairside support to a dental nurse working in an NHS practice that provides general dental care. So it's there to make it more adaptable for each individual, but while still working within what they've been trained to do. So it does briefly explain the limitations for each role, but because it's more descriptive, it can feel a little bit more confusing, because it doesn't just give you that straight, you cannot do this, you cannot do that. So it's just being more aware of what you can do in your own role. So what have you actually been trained to do? What was your course about? Did your course cover this? Did your course cover taking impressions? No, you need to do some training then before you move on to it. So as part of this document, it's also recommended that you read the GDC training competencies document. So this is where it feels a little bit more complicated, because you'll read this document and it will say, to understand what you can do, you need to read this training competencies document. So that document literally lists all the things that should be covered at each profession, each of their course. So what you want to try and do is that you've then got to try and tally up and understand who can do what. But on a whole, it does mean that there's a little bit more adaptability as dentistry is changing, because there's a lot more different products coming out, a lot more materials, there's new technologies, new techniques. So it does make it a little bit more open and a little bit easier. But on the same flip side, it can feel a little bit more confusing, because we've not got that clear cut, yes, you can do this, no, you can't do that. So why does it matter? Why does scope of practice even matter? Is it down to the individual? Well, really, it should be down to both the individual and the practice to make sure that everybody's working within their remit. Patient safety is absolutely essential. Patients have to come first. If we're prescribing the wrong antibiotics, it could lead to anaphylaxis. As I've said before, if a denture is incorrectly made, you can damage your soft tissues. It might not function as it needs to. So sometimes the team can feel pressured into doing something just to help that one patient out because you're really busy, you're short-staffed, because senior staff have asked them to do it. You might feel pressured, but you need to ensure that you're appropriately trained, you're indemnified and competent first. That's going to always be battered about, and that's always going to be the advice, even when you approach the GDC. They are advised that anything you want to do, you need to be trained, competent and indemnified to do it. So for leaders and managers, we need to make sure that we're not asking team members or pressuring team members into carrying out tasks that is outside of their scope. We don't want to upset them. We don't want to make them feel like they have to do something that they're not comfortable or they don't feel trained to do. It's really good to have that open culture. Staff can feel comfortable to say, hang on a minute, I'm not sure about this. I don't feel comfortable. I don't feel competent. I'm not sure I've been trained to do this. Then we've got professional accountability. So that's more on the individual level. So this is the heart of working safely within the individual scope of practice. Every registrant is personally responsible for their actions, decisions, omissions, regardless of what anyone asks you to do. You can't turn around at a GDC case and go, well, so-and-so asked me to do it, so I did it. It's not going to stand up. So you must be able to decide, make that decision yourself. Can you do it? Can't you do it? But you also need to feel confident to say, actually, no, I can't. And that's where it can be quite difficult. But it is okay to admit that you can't do it. It might be that you just need to be shown something and have a little bit of extra training on it. It might be that you're right and it's not within your competence or within your remit, so you can't give that treatment. Key thing to ask yourself is it in the patient's best interests? If a task is delegated, that delegator has to then be accountable. So, for example, if your dentist is asking your dental nurse to take an impression and they're trained to take that impression, that's fine, but the dentist needs to be assured that that person is also trained. So that's where there is a little bit of overlap with accountability. So if you're passing on some treatment to somebody else, you need to assure yourself that that person is accountable, that they're trained and they're appropriate to do that work. So it also protects patients from harm, and it will also protect yourselves from proceedings and reputational risk if you make sure that you're confident in and accountable for the things that you do. So the other thing that's really important is for legal and regulatory compliance. So working outside your scope carries significant legal risk and regulatory risk. So if somebody works beyond their scope or asks someone else to do it, as we've seen on the previous slides, you're risking fitness to practice action, healthcare inspector visits. With the GDC, you could end up with suspension, erasure from the register, formal warnings, which will stay on your record. It can impact your reputation. They can begin with something as minor as taking impressions and you're not qualified to do so, adjusting an appliance just to get somebody out of discomfort, providing whitening, or even prescribing medicines. So it's essential that you're meeting all those regulations, because not only have you got your professional, your GDC regulations, Health and Social Care Act, you've also then got, in terms of medicines, human medicines regulations. So it gets really complicated for some areas where there's a lot more to it than just, I gave a patient a denture or I gave them some antibiotics. So in terms of, sorry, just bear with me. So yeah, in terms of the CQC or HIW, they could take enforcement action on a practice because they could deem the practice not providing safe care because you're not working within your remit or effective care. So that can also then have a knock-on effect on the practice. So legal links in with business, because if you get enforcement action, you're not meeting regulations, you're at risk of closure. So again, making sure that everybody working in that scope to reduce that risk. You could also get fines as well for not meeting those regulations. Protecting the business side of things, your reputation is huge. I mean, think about how you get new patients to join the practice. A lot of it is through word of mouth. A lot of it is through 5-star reviews or whatever, feedback. They see you coming up on social media a lot, advertising. If it comes in the press that something's gone wrong significantly, patients come to harm because somebody was doing something that they shouldn't be, it's going to really impact your business from that point of view. People aren't going to want to go there because they're not going to feel safe. But at the same point, if your regulator discovers and gives you enforcement action or then closes you, that's going to impact the business as well. So it's really important that we work together to make sure that we understand what we can do as a whole to protect dentistry as a whole, to protect individual practices, make sure that reputation stays positive, because we see a lot of negativity in the press, about all sorts going on in dentistry at the moment. So we want to try and reduce anything else that could go wrong. So unlocking opportunity. This is where, after this session, it's probably worth just taking 10-15 minutes just thinking about how your practice is run. Think about your current structure. Do you utilize your team members? Have they got extra skills that they don't use? Have you got an intraoral scanner, for example? That's like taking an impression. It's a part of dentistry. So, have you got things that you can use, skills that you can use? You've got a therapist who's working at hygienist, just doing hygienist treatments, for example, or you've got a general dentist who really wants to transition to implants or do sedation, but they've not got the time, or everything's just so busy they can't develop those skills. So is there a gap? Is there something that you could do? Is the demand for it through patients? So we're really good as a profession at embracing digital change. Look at what's happened over the last 5-10 years, AI record keeping, you've got your AI radiograph interpretations, computerized patient software, if anybody's as old as me and remembers paper notes. We've got online training, digital rotors, there's online presence everywhere. But the bit that we're not so good at is that embracing operational change. We're all used to, some practices do it fantastically, but a lot of us tend to be stuck in that's how it's always been. So we just carry on. So don't get me wrong though, those that do make that change do really thrive, but it can be scary making that change as well, because it can, it can feel like it's a big thing for the business, a big thing for team members to get used to. So then you need to consider, at the moment, when you've thought about your current structure, what's working, what isn't working, because there will be areas that are brilliant. There may be things that need a little bit of improvement. Nobody's perfect. I'm not perfect. So there's always places where there's gaps and bits that could be improved on. Then think about, well, is everybody working within their scope, first of all? Have you got making sure that your dental nurses are working within their duties, providing that chairside support, be in that network for those patients? Are they providing anything else? Are they doing sedation? Have they been appropriately trained? Have they doing oral health education? Have they had that training? Fluoride application? The list goes on. So have they been trained to do what they're doing? And then are they doing anything above? So, if you've got a therapist giving out antibiotics, which is a big no. So you need to just have a little think about that. So is everybody doing what they should be doing, or what you think they should be doing? If there's anything you're not sure of, there's absolutely no harm in just checking with them. You could just say to them, is this within your remit? I just want to just double check, just to protect you, never mind everybody else. but it's there just making sure that everybody is okay. I get it, when we're so busy, sometimes you don't even see some of the staff because it's that busy in practice, but it's just important just to take that time. Then, is there room to build on skills? Have you got a dental nurse itching to do some additional skills? Have you got, as we said before, your dentist wanting to build on those cosmetic skills or implant skills? Is there areas where your practice can grow? There's always little bits where people can improve on skills, or they're not quite happy with something, or they quite fancy going on a course that they've seen because they think it will really help them develop further. And then you want to try and evolve the team. So it's all well and good thinking about these things. Where can you go? What can you do? But then making that change is what is quite hard in practice. The busy diaries, I get it. Some practices are booked 3, 4, 5 months in advance. So thinking about implementing change, wanting to bring in direct access, for example, it can be really difficult to implement when you've got such a busy diary. But if you want to make that change, it can then get forgotten about because you think, oh, that'd be really, really good, but I can't make any changes in the diary because I'm 4 months ahead, and then nothing then happens. So you've got to come up with a really smart plan so that you can actually implement that change. So if you're booked up 5 months in advance, make adjustments then. Come up with your plan. How's it going to work? Put blocks in your diary for different appointments so that then from that point on, it moves forward. You can prepare the team, train the team, make sure everybody's comfortable before it happens. So it's not always a bad thing that you've got that delay. But the bit that always falls off, though, is the thought about it and the action. So it's about putting it down and coming up with a good plan. And it will make a positive change as well, because people retaining staff can be difficult in the dental world. And if people feel like they're using skills and they're developing and they've got a really good career, not just a job, often they tend to stay, especially when they're working in that atmosphere where they're pushed to develop and they've got that opportunity. So by developing that team, you've then got that income potential unlocked. So, you've got more relief on your dentist if your therapists are doing your restorations, because your dentist could then do your root treatments, your implants, your more complicated work that involves any lab work. So it just gives you that bigger gap of potential. If you've got your dental nurse doing your intraoral scans for diagnostics, for your impression taking, you've even got the change in the NHS contract with the fluoride, and you can get 0.5 UDAs for your fluoride application through your dental nurses. So again, income potential for your practice there, where you've got to meet those UDA targets. So there's loads and loads of scope, and there's loads of gaps. You just got to start looking at where your practice is. I can only tell you on a general level, because all practices are so different with how they run, how they function, who does what, where the responsibilities sit, who the decision makers are. But it's all about looking at how you're working and taking that step back, because we all know we don't have that time. So give yourself that little bit of time. So we're going to touch on some common misunderstandings and queries, because these come up a lot. I see it on forums, we get queries. So hopefully this will just help give you a little bit more of an understanding. So trainee dental nurses, this often causes a lot of confusion. So you probably have seen through social media, through emails, that there is a change coming from the 1st of June 2026 that all trainee dental nurses must start a recognised training programme within 12 months. This was previously 2 years. So those that have started work before the 1st of June 2026 have until the 1st of June next year to begin their training, or within 2 years of their start date, whichever one is sooner. So the GDC expects trainees to have a formal induction when they're starting work, and this needs to include patient safety, confidentiality, infection control, safeguarding, medical emergencies. Trainees must receive that training must also receive training for each task before they carry out that duty and keep a log that they're doing. So you can use, we've got a non-GDC registered training log in iCompliance, so you can use that to keep a record of this. They may also have a log alternatively as part of their course, depending on if they start their course straight away. So that will vary on the course provider. But basically, they need to make it clear that they've been trained on how to do something. Practices need to consider time needed to support training for trainees. It's not as simple as you take on a trainee, you chuck them in surgery on day one, you leave them to it. They need to be supported. They need to understand what they're doing and why. And they need to be, you need to be supervising them to make sure that they're carrying out that job correctly, that they understand the importance of being consistent, for example, with your decontamination. So in terms of, that's something that people tend to struggle with because of how busy practices are. So it's something that they can miss off, and trainees can struggle because they're not getting that support. So it's just something to really consider if you're thinking about taking on a trainee. The GDC also expects trainees to receive encouragement and a wide range of experience throughout their training. So chucking the trainee in with a dental hygienist for the whole duration of the course isn't going to help that trainee develop in terms of providing chairside support for extractions, restorations, root treatments, checkups. So it's making sure that they get a lot of experience with different materials, that they understand the different appointments. So there's an awful lot to it rather than just thinking you get an extra pair of hands of chairside support. They do need to be supported. As we've said before about them being a safe beginner, they should be qualified as a safe beginner. And also they need to seek out that, get my words out. They need to get registered promptly once they get their qualification. So you can't just leave it a year and then go, I'll register with the GDC. You need to get that registration in place quite promptly, because it can take a little while to get on the register, as I'm sure some of you are aware. So as part of their training as well, they need to be adequately supported and they need to be supervised, which we'll touch on the next slide. So they need to feel like they're being supported by the practice as well and not just chucked in the deep end. Sometimes it can be good to be thrown in the deep end, but in terms of being a dental nurse and have patient care, they need to have that support before they're chucked in the deep end. So as part of that poll question, can a trainee dental nurse take clinical photographs, intraoral scans? So I reached out to the GDC about this one because historically, the old scope of practice document had clinical photographs and impressions listed as additional training, as an additional skill that could be done by a qualified dental nurse after they'd done their qualification. So my understanding was always that no, they can't, because it's part of that additional skill for a qualified dental nurse. So I spoke to the GDC about this because their new scope of practice document doesn't clarify it. It doesn't really mention photography. So I wasn't quite sure, or even impressions. So I wasn't quite sure. So they've come back to me and they've said that they can only practice dentistry that is within their training course, and as long as it's under appropriate supervision. So that's appropriate supervision is an appropriate dental registrant who, and we'll touch on it in a bit, but they've signed up to be that registered supervisor. So if a trainee's dental nurse, if their course includes undertaking clinical photography, if it includes intraoral scans, impressions, and the trainer, they've got a supervising trainer to train them how to do it, and the supervising trainer is indemnified to show them how to do it, then that's fine. Now, I've looked into this briefly and I couldn't find a training course that does cover this for trainee dental nurses, but I could be wrong because there's quite a lot of training courses out there. So it's just something to be aware of, that we're not getting people to do things that have always been accepted as it might be okay, so maybe just do it. We need to make sure that they're actually indemnified to do so. So you got to check two things there. If you want them to do clinical photographs, you need to make sure it's covered on their course, and then it's also covered with the supervisor and their indemnity. So it's quite key. So I imagine it's still a no, but that's one where it's a little bit of a maybe, depending on that course, because who knows, they could bring out other courses that do include it as well over time. So supervision, this is something that gets confused and often missed, but you have to have a registered dental professional who is responsible for directly supervising a trainee. They need to be named at the practice. So this is expected from the GDC. Healthcare regulators will check that you've got supervisors in place that are named and responsible for this. So it is important, and it will be checked. You can delegate your supervision. So you can delegate to other GD registrants depending on the trainee's progress. So the registered professional is the overall accountable person for that trainee until they are GDC registered. So that includes if they say you've got your principal dentist who is the named professional, and they delegate the training to one of your qualified dental nurses to support and develop that trainee. The supervising clinician is the person who is overall responsible and accountable for that trainee right up until they register. So it's really, really important that you understand that that's a big thing to have on your shoulders. I'm not knocking trainees. We need them. We need to get people in the industry. But it's just really important that if you're agreeing to be that registered professional, you've got to understand what the responsibility is. There's a lot of information about this on the GDC's website. And as we mentioned before about having a log of all of your training received, and it's regularly signed off by your supervisor, so that the supervisor and the trainee are agreeing you've been trained in this, you understand what you've got to do, and you know who to reach out to if you're unsure about anything. Indemnity, this also comes up. So does a trainee dental nurse need indemnity? So directly from the GDC, no, they're not required to have indemnity because they are not a registered dental professional. However, if their employer or the supervisor's indemnity, because you may have two different people there, their indemnity must cover being able to train them and supervise them while they're working towards their qualification. So there is an element of indemnity still, it's just not individual to that dental nurse. So they don't need to get it themselves because they're not a qualified dental professional, but there will be an umbrella employer's indemnity, and also the supervising person needs to have their own indemnity as well for that. So dental nurses, they are absolutely invaluable to the day-to-day running of a practice. We all know how hard they work, and I couldn't work without a nurse. They're absolutely fantastic. Absolutely essential for patient support and safety. So there's so many skills, as we've touched on previously, that they can develop into depending on the practice, the setting, the opportunity. You can do rubber dam placement, fluoride application, oral health education. There's loads of things that they can do to develop. So it's really important to try and enable them to be able to develop within your practice where possible. Healthcare inspectors love seeing that the practice has that support, that training support. You can be developed further so that you're improving your skills, and you've got that option to be able to do that. Not everybody's going to want to. Some people are going to be happy in their role. They're not going to want to change. But you're going to want some people. You'll find that you'll have some people that really want to develop, and that's where it shows really good leadership as well by supporting those individuals. And it also helps staff retention as well. If somebody's happy, they're not going to leave. If somebody's itching to develop and itching to grow, and they're just not getting that that's when they're going to start looking. And we know that dental nurses at the moment are like gold dust, and they have been for quite a while. So key point, dental nurses cannot provide tooth whitening. So they can support the dentist or the hygienist, therapist, clinical dental technician while they're fitting the trays, doing the first application of whitening, and while they're giving the instructions, but they cannot do the application of whitening or fit the trays. They cannot give local anaesthesia. So that one's quite key, as we saw on that first example. We had a dental nurse giving local anaesthesia. That is reserved for hygienists, therapists, and dentists. They also cannot prescribe antibiotics as well. So sometimes it can feel easy to do if you've not got a dentist in on that day, you've got a patient phone up. Oh, I know the dentist would do that, so I'll just do it. We can't do that because there's no protection in terms of your indemnity if it goes wrong. Might not be prescribed right, so that patient safety element. So there's a lot that could go wrong. Orthotherapists, so again, often forgot about because there's quite a few now registered, but it's a more niche topic. But orthotherapists will work under the prescription of a dentist or orthodontist. They cannot diagnose, so they normally work through the prescription. If they get to a point where they need to review, the dentist will review it. They can't modify arch wires, that's reserved for your orthodontists. And they can't carry out interproximal reduction. So for those of you that don't know what that is, that's where you reduce some of the enamel in between teeth by using a fine file. They can't do that because it's permanently changing the tooth structure. So that's reserved for dentists. So sometimes there's a little bit confusion with that because, again, it's where we fall into the, I'll just do it just to help that patient out, or we're running late, or we're really busy. But it's just really important that these things aren't done. Dental technicians and clinical dental technicians. Now, I know that there won't be many of them in the room, or there might not be many practices that have direct, a dental technician working with them directly. But it's still good to know where they can and can't do their duties. So the dental technician cannot perform any clinical duties relating to removable products. They cannot do an examination on somebody, and they can't fit removable prosthesis. So they can't fit dentures, for example. What they can do is they can repair a denture. So a patient can approach them directly and they can have their denture repaired. So, but the rest of their treatment will be done under prescription from a dentist or a clinical dental technician. Then you've got your clinical dental technicians. So these you'll come across more, as I said earlier, in your practices as well as in dental labs. So they can provide full dentures without a prescription, but they can't provide partial dentures. And that's just due to the complexities with the dentition. And they can't fit removable prosthesis in dentate patients or patients with teeth. So they have a more clinical role, though. They have a little bit more of a hands-on role with taking impressions. They can do examinations under direct access. So there's a lot more that clinical dental technicians can do, but it's just finding that line between fitting and making appliances for those patients that have got teeth and those that haven't. Hygienists and therapists, I could possibly bore you to death with the amount that I could talk about hygienists and therapists, but where it often gets confused. So hygienists and therapists can work to their full scope of practice under direct access. So for hygienists, that is your oral hygiene education, hygiene treatments. So you traditionally known as scale and polish. I know the name's changed since, but that's what a lot of people know it as. Your RSD, which is your root surface debridement. You've got your fissure sealants, fluoride applications, prevention. So that's where your hygienist sits. Then your therapist, in addition to that, will be able to do your direct restorations, so your composites, amalgams, extracting deciduous teeth, placing preformed metal crowns on deciduous teeth. So there's a lot more scope that your therapists can do. They can also supply and administer certain medicines under exemption or prescription from a dentist. That means they cannot prescribe. That means there are certain medicines like local anesthetics, fluorides that they can give under certain circumstances. Under exemptions means they're basically trained to provide that medicine to those patients, providing it's safe throughout their training. But they cannot prescribe it, so they cannot write out a prescription for them. They can also open and close NHS courses of treatments because they can get a unique PIN now. So there is a little bit of confusion around this still as to what it means. But basically, and this also applies to your dental nurses with the fluoride application as well. They can be given a unique PIN that is unique to that individual, and it means that you can open and close a course of treatment. For hygienists and therapists, it means they can do the treatment planning, etc. So it just is there to improve access for patients. And a lot of people get confused with that. But there's a lot that can be done with hygienists and therapists that's not done in practice. What they can't do, as I mentioned, prescribe medicines. They cannot fit dentures or bite guards, with that being a lab product. They're not trained to do that. And then a key one, I don't want to sound anti-overseas dentists because I am not. They are massively helpful with the shortage. Excuse me. But they cannot perform duties reserved for dentists. So they may be tempted to do RCT, prescribing, repairing or making dentures because it is something that an overseas dentist has done in their own country or other countries they've lived, and they've done it for years, and then they come over here and they can't register as a dentist at the moment because they're waiting for their ORI examination. I mean, I know that that's stopped now, but there's still a lot of overseas dentists who are registered as a dental therapist. And they may just get confused with that line, because if you train to do something and you do it for so many years and then you come somewhere else, come to a different country, and then you're told, oh, no, you can't, it can feel a little bit confusing. So it's making sure that, they're sticking to the remit of a dental therapist. So because they can't prescribe, they need to make sure they're doing the exemptions training as well. If you've got a patient come in and they're the only ones there, you can't just say, oh, just do that sort that toothache out, or just prescribe them those antibiotics, because they can't, because they won't be indemnified to do so. So, poll answers. Hopefully that makes a little bit more sense for you now. So, can a treatment coordinator who is not GDC registered take an intraoral scan? The answer is no. And that is because your intraoral scan is an act of dentistry. So they need to be a qualified dental nurse, or, as I discussed with the trainees, it needs to be included in their course. Excuse me. Number 2, can a trainee dental nurse take clinical photographs? Well, as we've said, it's a maybe depending on that course, but it's a likely to be a no. And that would depend on the individual. So it's worth just checking with that course if you really want them to be taking clinical photographs, but it's probably going to be a no. And then finally, can a therapist prescribe antibiotics to a patient? No, because prescribing is served for dentistry and reserved for dentists only. So as a summary, try and understand the scope of each of your roles and the capabilities of your team. So for one person, they both have the same qualification, but one may be a lot more confident and feel competent in doing one part of that role, whereas another person might not be. So it's just understanding your team and their capabilities. Make sure that everybody's working within their professional boundaries, so you've not got people prescribing or providing dentures or tooth whitening when they're not trained or indemnified to do so. Try and have a look at where efficiency can be improved. And that's quite key. Give yourself 5-10 minutes every so often. Just have a sit back and think about how things are being run and what could be different. And you'd be amazed at what you can come up with and how it can really help the team. And again, looking at your scope of practice for the team, it can improve your staff satisfaction and productivity as well, which again, in turn, improves business performance. So, any questions? I'm just going to go over to the Q&A. You have to bear with me. I'm sorry, I'm losing my voice. So, first one, we've got Holly. Can a qualified dental nurse be registered with the dentist indemnity, or should it? Or does it need to be to the individual cover? So, I believe it can be within the dentist indemnity if it's really specific and clear on that policy that it is covered, and the dental nurse needs to be able to be aware and see that policy and understand it, because the dental nurse will be signing a declaration every year when they re-register, when they update their, sorry, I've lost my thoughts of what it's called. When you pay for your annual GDC, when you pay for that, you have to do a little declaration to say that you're indemnified as well. So with that one, if you're unsure, it's worth having a chat with the indemnity, because they're the ones ultimately will say whether it's covered or not. So we've got Carol, can a dental nurse or receptionist sell repeat Durafat toothpaste if there's no dentist on site? If a patient walks in and just comes to the desk and says, can I pick up some toothpaste? The answer is no, because it is a prescription only medicine. The dentist needs to have checked those notes, make sure that it is suitable for that patient, and the dentist will need to label it up as well. So it need all that in place before it's then given to the patient. So there's a lot of confusion with that, but those people who are iComply members, if you have a look at our medicines overview, there's a big section in there about labelling medicines and what the label needs to contain. So you need to make sure that that's labelled up before you give that to the patient. What have we got next? So we've got Danielle. Does a hygienist therapist require a signed consent form for a patient to provide direct access? And whose responsibility is it to ensure the patient is aware of being seen by direct access? So the consent form, no. At the moment, and the GDC standards, the only things that you need a consent form for, and now you're testing me because my mind's gone blank, it's if it's under sedation or GA, there's 2 points, I can't remember the second one, but basically you only need a written consent form for 2 procedures. It's in one of the GDC standards and I can't for the life of me remember the quote. So no, you don't need one written. However, it can be helpful to make sure that the patient understands what it is. But it's no good just giving the patient a list that literally says, this is everything a hygienist and therapist can do. They can't do they can't do X, Y, and Z. You need to see a dentist for that. They need to just understand what a hygienist and therapist is, and that they will refer to a dentist to anything outside their scope. The responsibility for who to ensure the patient is aware of being seen on direct access, it probably sits with the whole team. So the dental therapist, hygienist will need to make sure the patient's aware when they're coming into the appointment. But then the reception team, whoever's making the booking, needs to make it clear what it is, that there's no dentist, doing dentist checkup whilst the therapist can do an examination within their remit. They need to just understand what that difference is. Some patients don't want to see a dentist, whether that's phobia or they just don't like dentists. So they may be happy with that, but it's just making sure that's really clear. So what's quite key is making sure the whole team understand what direct access is, so that message is the same throughout when somebody does any inquiries. So we've got, can you please tell me if a trainee dental nurse can use a 3-shape scanner? So that is the same as the dental nurses in the clinical photographs. So it would very much depend on their course. So if scanning, impression taking falls under their trainee course remit, and they've got the right supervision, and they've got the supervisors indemnified to show them to do this and for them to do it, then yes, that's okay. But if it's not in the course remit, then no, probably not. But it may be that courses develop over time that they will be. If a patient requires antibiotic cover, if it's prescribed, who in the practice can administer it to the patient on the day? Normally, the patient will take it themselves, but because it's prescribed, it would usually be the dentist. Normally, they take it about an hour before treatment, though, and often it comes from the GP more than the dentist these days. But I could be wrong on that, but I'm pretty sure that normally it will come from the GP. And these patients will, they'll normally take it, sit in the waiting room for an hour, or take it at home, depending on that setup, and then they'll come in. So yeah, who can really it'd be the dentist giving it to the patient, or it would be very similar to it being labelled up appropriately, as you would do with that toothpaste. But really, the dentist needs to be the person who's supervising and overseeing that. Are you required to display the scope of practice? No, you're not required to display it. In terms of the scope of practice document from the GDC, it's an 18-page document. So I don't know about you guys, but some waiting rooms can be already overwhelmed with posters and all sorts. So no, you don't need to display it. You just need to make sure that everybody's aware within your team who can do what, so that if you've got a patient asking, or can you see somebody for X treatment, you know, there's people understand that they can't be seen by a certain person because they're not trained to do that role. A lot of our receptionists are GDC registered but are not clinical. Do they need separate indemnity? No. So in terms of your reception duties, some of that may fall within your dental nurse duties if it's like certain advice over the phone, but they just need to have a chat with your indemnity for your quote. So if you're definitely not doing any clinical work, then it may vary what's on your indemnity. But because you're GDC registered, you will need a level of indemnity. But I'm not an insurance provider, so I can't give you the advice on what level of cover you need. Can we sell whitening gel to patients as an ongoing treatment that has been prescribed by a GP? So whitening isn't a prescription-only medicine. It's a cosmetic device. So there's different rules and different regulations to whitening as there is to medicines, but it still must be prescribed. So if there is a prescription on that record for that patient, then yes, if the patient has been seen, they've had their examination, the dentist is happy that they're fit and well, and they want ongoing whitening, yes, they can be prescribed it. That's absolutely fine because that's within the dentist's remit. In terms of whitening, if they're unsure, it's probably worth them going on another whitening update just to make sure that they're covering themselves. But yeah, normally the dentist prescribing it and overseeing it is absolutely fine. Yeah. So yeah, that question, the question there about presuming it's the same for whitening as Durafat. Again, that's just where it's slightly different because your whitening isn't a medicine, and that's key. And that's where we really get a lot of confusion within the industry. And then Angelica's asking about trainee indemnity. So as I said on a previous slide, the GDC don't expect trainees to have indemnity because they're not a registrant. However, the supervising GDC registrant needs to make sure that their indemnity covers them for supervising those trainees. If a dental nurse, we've had one off Carol here, if a dental nurse sheaths a local and has a needle stick injury, can she claim off the practice knowing that this is not within her scope? I'm not too sure because that sounds like an insurance query. But if somebody's been trained to do something and then they've gone and done something different, it's not likely. But again, that would be more of an insurance question than compliance, I'm afraid. So sorry about that, Carol. I've had one from Taylor. Is there a timescale of how long we can sell whitening syringes after the initial whitening course? Off the top of my head, I cannot remember. I think it's down to what's written in the dentist notes, in the dentist prescription. And they should have a recent examination, but there's no time frame given on the advice as to a recent examination. So that one's a little bit difficult. Can a GDC radiography trained nurse do a CT? I think they can, Jacqueline, but I'll have to double check on that one and get back to you. I think they have to do additional training, and I think they can take it. I think it's in the radiograph, the CG Dent radiograph guidance. I'm pretty sure. I'll make a quick note of that, and I'll find the answer out for you. But yeah, I'm pretty sure they can. We've got any other questions? No, well, because it's gone over a little bit, I do apologise because I know a lot of you will be going back to clinic now. But if you've got any other questions, you do know where we are with Helpline. And feel free to give us a call if you've got anything that you're unsure of. But as well, don't forget your indemnities are there as well. They are really, really helpful. And there are another source that we often forget about. But yeah, as I say, you know where we are. And thanks for joining and have a good afternoon.